Welcome to Are We Ready? Preparing your clinical team for delivering hospital-at-home care, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. David Levine. Dr. Levine is a practicing general internist and clinician investigator at Brigham and Women's Hospital and Harvard Medical School. He is active in clinical and translational research through a focus on optimizing quality time at home by shifting care home, decentralizing care, digital health technology, and measuring the quality and experience of healthcare. He is a member of the Hospital at Home Users Group leadership team and directs Brigham's home hospital efforts. Please take it away, Dr. Levine.
Thanks, John, and good afternoon, everyone. Really excited to be with you all. We have an amazing lineup of experts in the field today who are going to be talking to us about how they train their teams at their respective institutions and organizations. So really excited to tell you a little bit about what's on tap. Just as a reminder about the Hospital at Home Users Group, we are essentially a convener of home hospital programs throughout the country and Canada and elsewhere. We are completely free to be a part of. We welcome anyone and everyone who either wants to be an affiliate with us or a member with us and actually takes care of acutely ill patients in their home. Please check out our website, check us out on Twitter. And as John mentioned, all of our technical assistance materials are completely free of charge at our Technical Assistance Center, and really welcome you to go there as well. Really also want to acknowledge again the John A. Hartford Foundation support of the Hospital Home Users Group. Without them, we would be nowhere. So we're very grateful for the John A. Hartford Foundation. If you haven't had an opportunity yet, we have an entire lineup of webinars over the last several years now of helping to train and equip home hospital programs all throughout the country. Trust me, you won't be able to go to sleep if you tune into these. So just be careful. As soon as you start watching, you're going to have to binge them all. And as we've mentioned, they are all completely freely available online on our website. And so today's webinar, again, very, very great cast of characters we've got for you today. And really the title here is, Are We Ready? Preparing your clinical team for delivering hospital at home care. This really comes out of demand from our users group and all sorts of folks across the country, recognizing the fact that we are demanding a special kind of clinician when it comes to providing acute care in the home. This is not a traditionally trained hospital-based clinician. It's not also only just a traditionally trained home-based clinician. And we really do expect there to be some really wonderful as well as creative minds delivering care in the home. And so we're excited to hear about how people are doing that in various expert institutions and organizations across the country. So we're going to have three people tell us how they're training their teams. The first is Zio Dorrejo. She is a nurse practitioner at the Hospitalization at Home program at Mount Sinai Health System, where she cares for acutely ill patients in their homes. She also serves as a member of the Quality Improvement Work Group, and she trains nurses and providers in the hospital at home model. She has spent over 15 years in public health, home health, and hospital at home. Our next speaker is Patrick Neeland. Patrick is the VP of Medical Affairs at Dispatch Health, where he designs and leads the Advanced Care program, bringing hospital-level care to patients' homes. He is an experienced speaker, facilitator, leadership coach, system designer, and in his words, a zealous destroyer of all those silos everyone always talks about. And our third expert with us today is Doug Clark. Doug is a practicing general internal medicine physician and is president of TetherMed, Medically Home's mobile integrated health solution. Doug earned both his undergraduate and medical degrees from the University of Virginia, and he completed his residency at George Washington University. So we're really excited to have all three of you with us. We're going to start off with Zio, and just so folks know what to expect, each expert is going to give a short talk on kind of how they prepare their teams. Zio is going to focus on nurse practitioners and APPs, as well as nurses. Then we're going to have Patrick mostly focusing on physician care, and then Doug focusing on mobile integrated health and paramedicine training. And in between each, we're going to have the experts kind of have a small conversation, ask questions of each other so that you all can get an even fuller understanding of their expertise. And please, the whole time, give as much Q&A as you can, because we'll have time at the end to answer your questions. Zio, off to you.
Thank you, David, for the introduction, and thank you to the high users group. So my talk today, like David mentioned, is training nurses and nurse practitioners. So over the past 8 years, Mount Sinai's Hospital at Home program has trained over 50 acute care nurses. We've trained over 8 nurse practitioners. Our onboarding process typically takes anywhere from 3 to 6 months. And this time frame depends on the employee's experience, their background, whether they came from a home care background or an acute care background, and their comfort level with performing home visits. We start off by conducting a needs assessment of staff training needs based on a list of core HA competencies that we've created. So we did create a competency checklist that we use to help guide our training. We do use a variety of training modalities, from didactic sessions that occur in person or remotely. We also offer e-learning modules to our nurses and nurse practitioners. We do have a module online on home visits. We also offer hands-on skills lab where our nurses get an opportunity to practice those core hospital at home skills like phlebotomy, drawing blood cultures, inserting IVs, administering medications through IV gravity or IV pumps. We train our nurses in wound care, training them on indwelling Foley catheter management. So the skills lab training sessions offer our nurses the ability to practice in a safe learning environment. A lot of these skills that they will then use in the home setting, and they apply a lot of the knowledge that they gained from the didactic training sessions. Our acute care nurses and nurse practitioners are also given the opportunity to shadow the interdisciplinary teams. So they go out and observe our care coordinators recruit patients from the emergency department and the inpatient floors. They have an opportunity to go out on home visits with the nurse practitioner, with other nurses. They meet with our social worker. They meet with our HA physicians who admit the patients. So they get firsthand experience or shadowing experiences that allow them to see how our hospital at home program works. We also review simple and complex case scenarios with the nurses and nurse practitioners, and we perform mock patient visits. And here we basically run a full visit from the time that the patient has been admitted, what a start of care visit looks like, what a follow-up visit looks like, a discharge visit. And then we offer constructive feedback. And of course, we collect feedback from the nurses and the nurse practitioners. We also pair up our new staff with an onboarding buddy. So we do have a buddy system in place to offer support and guidance throughout their entire training period. And then once they're ready to start seeing patients or managing their own cases, we gradually increase their patient caseload. We start off with 1 patient, then 2, then 3, work their way up to the max caseload. We also provide our nurses and nurse practitioners with all the equipment, technology, the supplies that they'll need in order to perform their roles. We provide them with telephones and tablets, digital stethoscopes, nursing field bags, and all the little kits that they'll need, lab kits, IV kits. And we go through all the contents of their bags, all the equipment. We also provide them with training materials. So we do have a binder where we have all of our protocols in one place. We also offer them tip sheets and guides to reinforce a lot of the training that we offered in the didactic sessions and the skills lab. And all of these materials are located in a hospital at home app that we've created. There's a picture there with all of our policies and procedures, all of our guides and toolkits. It's a lot to keep track of. And so this is one big repository of information that's easily accessible, and our staff can access it, from the patient's home, in their Uber. We also evaluate our nurses and nurse practitioners periodically, either 3 months and 6 months, just to see, they've been able to apply a lot of these skills, how they're performing. We also obtain feedback about how they're feeling, if they feel like they're ready, if they feel like they need a longer training period. We do offer refresher trainings, especially if a nurse or a nurse practitioner hasn't cared for a particular patient in a long time or hasn't used a skill in a long time. We will offer refresher trainings. An example of this is our infusion pumps. We may get a patient now and then that requires a infusion pump. And then we may not have another patient requiring an infusion pump until maybe 3 months from now. And so we do offer training sessions to kind of brush up on those rusty skills. And then if we're planning any new initiatives, planning to take on new patients, using new equipment or technology, we do offer trainings before implementing these new initiatives or changing any of our workflows. During the didactic session, this is what our typical training curriculum covers. We do discuss the hospital at home model. We offer a little bit about the hospital at home model history, some background information about our program. We discuss the workflow for the admissions process. So the step-by-step process to admit a patient. We go through the workflow for an acute phase while the patient is in the acute phase through the monitoring phase. So start of care visits, follow-up visits, discharge visits, the type of follow-up that we perform during the monitoring phase for those patients that qualify for the monitoring phase. We go over all of the team roles and what their responsibilities are so that they know who to contact. Let's say if they want to coordinate the delivery of medications or if they need help escalating a patient back to the hospital. We go over our team communication and sign out process. We do have morning huddles, afternoon huddles, admission huddles. We use a lot of web video conferencing to communicate with each other. We go over all the logistical aspects of admitting a patient, all the care coordination. So all of our services, pharmacy services, infusion services, durable medical equipment, oxygen therapy, transportation. So we cover everything that's involved in coordinating the care for our hospital at home patients. And then we do go over different workflows, what the workflow is during the weekdays, during the weekends, what type of support is available on the weekends. We go over home care safety and best practices, so the fundamentals of making a home visit. We do go through a step-by-step process of what a home visit would look like, what a telehealth visit would look like, how to perform a physical exam through a telehealth using the electronic stethoscope. Again, we go over a lot of the policies and procedures related to any of the skills that we perform in the home, managing lines, catheters, and a lot of our policies and procedures are a combination, or we've adapted our hospital policies and procedures with the home care policies and procedures. And then lastly, for our nurse practitioners, we do focus on going over treatment guidelines, how to place orders, medications, labs, discharge orders, how to refer a patient to home care services. We do mock documentations as well with a test patient, the different smart phrases that we use for our documentation. We go over billing codes, how to report incidents, what's the process for escalating a patient back to the hospital, and what the indication is for escalating a patient. Again, this is just a sample of one of our competency checklists that we use with our nurses. So in summary, what I find, we do get a lot of feedback about our training curriculum and our program. And our nurses and nurse practitioners find that after going through this onboarding process, they feel supported, they feel more confident, they feel like they're ready to work in a hospital at home program.
Thank you, Zio. Appreciate this really detailed rundown. I wanted to have Patrick come in. Wonder, Patrick, if you had a kind of question you're seeing here.
Yeah, thanks, Zia, for the presentation. I'm curious, I know you focus on, seems like you focus on nurse practitioners in your model. I wonder if in your guys' experience, if you've seen PA training or any differences in how you've brought in APPs of maybe different clinical backgrounds. So either PA and NP, or folks that have a ton of inpatient experience versus not, or any new grads versus experienced, any of those differences that have stood out in your training and getting folks up to speed.
Right, so on our program, we've only hired nurse practitioners. We haven't had any physician assistants, but I do find that our staff have a mix of education and background. Minimum, they have an experience from 2 to 4 years experience. We have nurses that have worked in the emergency department, telemetry, home infusion, home care. We had a nurse that worked in a peritoneal dialysis clinic. Our nurse practitioners, we've had some that have worked in the emergency department, others that have worked in a transplant unit. And then we've had a number that have come from home-based primary care. And I do find that we, the nurses and nurse practitioners, given the varied skill sets, it complements each other. One person trains another person, one person can learn phlebotomy from the other person, one person can, caring for acute care patients versus caring for home care patients. So I think having a diverse group really helps with the onboarding and training.
Great, thank you, Zio. And Doug, what about you? Thoughts there?
Yeah, thanks for the awesome presentation, Zio. One question specifically about RNs, especially if they're coming from the inpatient wards. It seems like a challenge to take really expert brick and mortar nurses from previous roles and move them into a new situation where they're honestly initially novices at doing this type of care. I imagine that's a tough situation to bridge. And has there been anything specific to kind of acknowledge that and help these expert nurses who kind of transition through that period?
Yeah, we do take that into account. We do have some nurses with acute care backgrounds that may not have the home care experience, and they're very vocal about that and a little hesitant and a bit intimidated. But I think with our onboarding process, just given the duration and how much time we invest in training our staff, by the end of the onboarding process, I find that they feel more comfortable. I mean, we do offer a lot of support, whether it's by phone, in person, even virtually. We have nurses that work until 12 a.m. and on weekends, and we do offer support for those nurses. So there's always someone available to guide them and help them out. And even our nurse practitioners that go out into the home can also provide some of that education in the home when they're in the home. So they're always well supported. I think it's why it's important to have a very comprehensive program for this type of model.
Zio, I'm wondering, you mentioned kind of several technology pieces. Do you all insource all of your training for tech? Do you like bring in some of the vendors to do that training, or do you do it all yourself?
Great question. So it's a mix. Some of the training we provide ourselves, but we do have vendors that come out and teach our nurses. Let's say, for example, our oxygen vendor, we've had them come out to train our nurses on how to use some of the oxygen equipment in the home, which is a bit different from what you see on the inpatient floors. We have had our home infusion company vendor come out and do a training session on using the ambulatory infusion pumps, which can vary depending on the model. And we've also had speakers come from different departments to provide teaching. And during the early years of our hospital at home program, when we had a little more time on our hands, we did coordinate with our nursing education department to perform skills lab sessions in the nursing education office. And we also collaborated with our emergency department to go out and have our nurses train with the emergency department nurses to use some of the equipment that we use, like drawing blood or inserting IVs. So it's been a mix between our staff and some outsiders that have helped train our nurses.
Great. Awesome. Well, thank you very much, Zio. Really interesting for nurse and NP-led training. Want to move on now to the docs. Patrick, how do you all do it at Dispatch for MD training?
Yeah, thanks, David. And so when we think about this, a lot of folks around the country, as we're working with partners and as we build on our own internal physician teams, the key question that comes up is, this one: can we just plug in any of our docs into this? And how should we be thinking about this? And as we've, walked through and built on, several years of experience taking care of patients like Klein on the right here, this 91-year-old gentleman with, heart failure, moderate aortic stenosis, cognitive dementia, who we admitted onto our advanced care service as an alternative to inpatient admission. Thinking through, we're bringing highly complex patients with multiple comorbidities and a lot of moving pieces around things like social support and this patient's case, cognitive decline. How do we find people who are eager and willing and creative to step into the role of taking care of patients like Klein? And so I'm going to walk through the three key elements that I think we've honed in on. How do you think about the right talent upstream of training? How do you train to what physicians are going to want to know and are going to care about? And then what does ongoing professional development look like in this novel care environment? So in terms of attracting the right people from the physician side, I think a couple of key things have started to stand out for us. And again, you can see another patient with another one of our patients on the right who we took care of, again, has a lot going on. And so there's a piece around value alignment. We found that physicians who thrive in this environment are really excited about this concept of entering someone else's domain, and whether that be remotely or physically moving into the home to care for these patients. There's a subset of folks who are really attracted to that concept and who are comfortable with the power dynamic, flip that happens when we're, moving into a home rather than when we're comfortable on our own turf as physicians. So value alignment is key. There tends to be a subset of folks who are more comfortable with being agile and creative. So a lot of what comes up in a home caring for a complex patient is unanticipated, circumstances, either around, oh yeah, I would usually choose this antibiotic, but unfortunately that's a 4 times a day antibiotic, and that's just not going to fly in the home. How do we think through either working, with the family to figure that out, or being creative around an alternative choice? There's a lot that comes up around the evidence base and the humanity of the patient. And this is the evidence-based recommendation, and the patient's sitting there saying, I'm not going to do that in my home, and here's why. And so thinking about that, how those things interact, the humanity and the science, is so important. And then I think there's this piece around folks who are open to what we might call a flattened hierarchy and really comfortable with the team dynamic. We all rely on our colleagues in nursing, our advanced practice colleagues, our ancillary providers, pharmacists, et cetera, in any clinical setting. I think that the premium on that goes up about tenfold when you're navigating multiple moving parts around someone's home, and there's literally a remote element at play as well. So the comfort with really being, creating an open environment for communication tends to be important. So folks who are aligned in this way, more likely to be successful. Second thing is we have our formal onboarding for clinicians, and we replicate it for nurses and APPs as well, that we call the Advanced Care Academy. It's a blend of in-person and then mentored, shadowing for several weeks beyond that in-person. And really, we walk through all of these things that clinicians care a lot about. How do I know that the care is safe? How am I going to be supported in that? Are we really bringing value? And show me how we're bringing value, because this is really important to me. How do we select patients appropriately? What are the clinical pathways, and what clinical decision support am I going to have? What does this mean for the rest of my clinical scope? Can I do this and keep my clinic? Can I do this and see patients in the hospital? What is this a springboard to, et cetera? And then finally, what logistical support am I going to have? So we marry our formal onboarding around a lot of these key questions that really get our clinicians comfortable around what care in the home is going to look like. I tend to think of the novel nature of what happens in the home with our clinicians in kind of two domains. There's sort of technical novelties, like how do I use this technology, and how do I maneuver the logistics? A lot of the tacit knowledge, like how do I get stuff done in my environment, is new when you're talking about these models. There's things like safety-based protocols. How do I escalate a patient if I need to? So there's a lot of technical novelties. There's also obviously a lot of cognitive novelties, again, around patient appropriateness. How am I comfortable in the home? How do I think about clinical reasoning in the home? There's some differences there. And again, this piece around leading an interdisciplinary team. And so as we're training folks in our Advanced Care Academy, we're training the technical aspects for sure, the likes of which Zio was just going over, but we're also planting the seeds for the cognitive pieces that become super important in the ongoing professional development. And so what training modalities do we leverage? So certainly an emphasis on our individual and team-based onboarding, that Advanced Care Academy, where we're bringing, there's tracks for each of the professions, but also group training that leverages that team dynamic and really focuses on that. We have ongoing team-based hardwired professional development. So this happens in recurring structured peer-to-peer learning. So we have scheduled topical discussions. For example, we may have one on how have you found creative ways to do shared decision making in an in-home environment, for example. We do an interdisciplinary case review series. So monthly, we have national reviews around key cases and key learnings around those cases. And these are just a few examples of how we do this, but again, structured interdisciplinary ongoing development. And then one I'll call out, which I think is pretty cool, and we found it to be really important, is this ability for folks to have someone to call in real time as they're encountering new things. I'm an internist. I'm nerdy. We call this thing another set of neurons, which is get another brain involved, get some eyes involved, get some ears involved. Never feel like you're making a clinical decision in the home where you're not comfortable and you're seeing something new or that feels out of the norm. So providing real time, phone a friend, if you will, across the country as we're encountering things in the home. So I'll stop there, and we can have some ongoing discussion around training clinicians in the home.
Yeah, Patrick, thank you. Curious, Zio, your thoughts and maybe questions for Patrick.
Patrick, I was wondering what has been the biggest challenge with training your physicians in your program?
Yeah, thanks, Zio. I think that for the most, and that's why I put in the physician selection part of this, is that what we've learned is if you attract sort of the right predisposed folks, the training is much smoother, and the ability to flex is a lot smoother. And I bring that up because I think for most physicians that I talk to about these models, really the hardest thing for folks to wrap their mind around is, oh, so you're taking care of like complex primary care patients, or, oh, you're doing OBS care at home. And it's like, no, we're substituting inpatient care. And that paradigm and training people to comfort around that has been, I think, both the biggest challenge, and I would argue, one of our biggest successes in the training to date. Thanks for the question.
Yeah, I'm curious, Petra, once you have them in your clutches, like what's the next toughest thing to kind of get them to either grasp or to train them on? I'm curious your experience there.
Yeah, I think that it's interesting. There's an interesting difference that we've noticed and that we train to around what I might call it all hands on deck mentality. So if in the hospital you can write an order, walk away, know that it's going to get done, go check Epic later on, or whatever your EMR is later on, and get the result of what you just ordered. I think a lot of these models require all of the disciplines to have some cross-functional knowledge and skill sets. So, if we have APPs that are in the home, we have physicians actually in some of our models that are in the home. They may need to learn actually how to draw a lab and run a lab in the home. And for a lot of folks, they hadn't done that since med school or when. So some of that cross-functional training, I think, can feel novel, can feel a little bit unusual for docs to have to step into and to learn. And we found that it's really important to do some of that cross training.
Great. And Doug, you?
Yeah, Patrick, thanks. You touched on this a little bit in the types of hospitalists or docs you recruit. Have you experienced kind of unease or uncertainty with doctors new to this level of care, just not being able to lay hands on the patient every day? So on their schedule in the hospital, you choose to go in, you see the patient, and instead it's just totally different.
Yeah, great question. And so certainly one of the things we have identified as a premium high ROI trained skill set for these models is team communication. So we all know, and there's been a lot over the last 2 decades around the importance of team communication in the brick and mortar traditional setting. Again, from my perspective, you take that importance and you amplify it 10x for what it means for a physician APP or a physician RN or whatever the combination is, where maybe the RN's in the home and the physician's remote, and what does that communication look like to make sure that everyone feels confident in the clinical decision making. We also prioritize training to really bring the family and the people and the patient's people into the conversation on a routine basis. Again, to make sure that the clinical decision making, especially if you're substituting for laying hands on the patient every day, is comprehensive, is thinking at 360 degrees, and we're really making clinical decisions that, yes, uphold the evidence base and are going to be practical in the home. So there's a couple elements there. And then the third one I would add, Doug, is really the comfort with cognitive practices in the home. And I think you have probably seen with your folks and others, there's just a difference when you're making clinical decisions truly immersed in someone else's life versus making clinical decisions, and you may call it a more sterile way, in a clinic office, or standing over a patient's bed around that. So that cognitive sort of leap from like, well, this is how I used to do this, but this isn't going to work for this patient, and getting people comfortable with that. And that's why I think that peer-to-peer education and the ability to do another set of neurons in real time has been so key.
Yeah, Petra, I was wondering, could you touch on that other set of neurons piece a little more? Is this like is it a schedule that you offer, and then everybody has a backup pair of neurons at all times? It's like on call for them, or is it more informal, or how does that work?
it's kind of in the middle between formal and informal. And the way it works is there is a formal schedule of physicians who are on, across the country, for example. And like a lot of the soft skills in medicine, there's a key training piece here around the cultural expectation. In other words, you're not weak if you have to ask a friend for another set of eyes or ears. And actually the opposite, that this is a sort of a cultural expectation, and we all learn every time one of these calls is made. So there's in the structured educational sessions over time, that concept is reinforced. So another set of neurons is something we talk about almost every single one of those, for example. And then on any day-to-day, folks know who's on clinically across the country and know that they have that network of folks to touch base with at any given time. And then we reinforce it on the back end by making it visible, say on the next national huddle meeting, for example, to say, hey, I just want to let you guys know, like I had a really challenging case. I called Doug for another set of neurons. It was super helpful because we figured this and this out. And I encourage other folks to leverage another set of neurons. So it's kind of the three-pronged approach, making it an expectation, not something that's weak. Setting up a formal way of people knowing who's on call, who they can call, and then closed loop reinforcement around this worked, and I had good experience with it. So that's how that works.
Great. Yeah, thank you. That sounds like quite an amazing part of kind of a very great training modality also for people to learn from other mentors and more experienced clinicians. It's great. All right. So we're going to move on to the paramedics. Doug, take it away.
So glad to talk to you guys today. Humbled to come up at the end here. I imagine the paramedics and mobile integrated health is probably what this crowd is least familiar with. But we think it's extremely important at Medically Home. And a little bit of background here, as we've grown our hospital at home programs over the last 3-4 years, you run into different learnings along the way, and we just really became strong believers that the clinician, I call clinician of the future, clinician of this level of care that can really do 70-75% of those inpatient visits needed to do a successful hospital at home program, is an uptrained, upskilled, tech-enabled, mobile integrated health provider. Typically, that's been a paramedic. This is the provider that runs into probably the most regulatory concerns of the groups talked about today. It's wildly different by states. Happy to get into that with folks offline. Some states are good, some are not for this provider. But a couple of the reasons we feel strongly is great kind of doer skill set that's been used in 911 and EMS for a long period of time. And I'll get into this in a little bit, but some the skills that they don't have in home, many of them can be taught in an academy-like scenario. A couple things that make sense when you hear them, but you may not think of initially, is these providers, along with fire, EMS, I mean, given their background, are really comfortable entering any home at any time in any area of the city. That's a skill set. It's a soft skill set earned over time, but not everyone can say that. They have typically increased staffing hours, schedule flexibility, and so it makes nights and weekends a little bit easier to cover. And also, I feel pretty strongly that there's an opportunity to improve health equity with this group by hiring and training community paramedics and other MIH providers from the community, and as you need capacity, growing from that group as well. So let me talk about kind of breaking this down into 3 groups. This first one we're going to talk about is the Medically Home Academy. We have that we do as a boot camp before one of our hospital at home goes live. And then post go live, we have a sponsored paramedic training course that I'll get into. And this is all leading up to a culmination in what we've decided is our aim for our training program, which is the International Board of Specialty Certification, Community Paramedic Certification Examination, CPC. So as far as the Medically Home MIH Clinical Academy, Dr. Evan Berg, who is really the driver at Medically Home in creating this on our end, along with Peter Carlson, has adapted this, and this year I think we've already done 7 different clinical academies. They last about a week. There'll be probably 8 to 10 paramedics each. And you'll go in and have this awesome immersive experience for a week. It's didactics, hands-on skill training, case-based simulation, all run by board certified emergency physicians, clinical nurse educators, and community paramedics. Often include, and we try to include personnel from the anchoring health systems to ensure the MIH providers are trained in the local protocols that they're going to need as well. The learning objectives can be broken down into 4 main categories. There's a clinical assessment, pharmacology, lab medicine, and skill training. For the clinical assessment, it's history taking, interviewing, physical exam, case presentation, and other documentation. And again, this can be tailored to the specific needs of the health system customer. And the case-based simulations really focus on the MIH provider clinical assessment and presentation skills, as well as the data acquisition and interpretation. And the goal is really to model the interaction between the in-home clinician and the hospital at home team in our command center, which is the group that really drives the care in our program. From the pharmacology standpoint, medication is formulary specific to the hospital at home model. Some of these are a little bit different than what paramedics might be used to carrying. We carry over 70 meds at a time on our trucks. These include antibiotics, diuretics, and this also gets into a little bit deeper knowledge base of clinical indications for the meds, the monitoring parameters, infusion rates, compatibilities, contraindications, and such. For lab medicine, in this portion of kind of the pre-go live clinical academy, the focus is on the point of care lab values that we use with our iStat machine. So CG4, BMP, CBC, liver function tests, UA, and the clinical presentations of common abnormalities these folks are going to be seeing in home. As far as specific skill training, this varies, and we have to take account for the academy participants. Some will have skills that they've developed along the way that may be atypical for EMS, and they need less training there, but we make sure that IV placement, phlebotomy, blood culture collection, are certainly covered. This includes training around indwelling vascular lines, like ports, tunneled lines, PICCs, and midlines. We go over sterile technique, basic wound care, urologic procedures like Foley is a big one that comes up, ostomy care, and then, as I mentioned, the point of care testing. So all this is really designed as a 7-day period of, and it's the culmination of a month of making sure that all of our medics and MIH providers are checked off, and we feel comfortable saying that this medic is world-class and will represent our customer health system well in the home with the patient post go live. So this is something we're pretty excited about, and we're going to roll out something a little more official soon, but it's been underway with a couple pilots. So after go live, we're sponsoring all of our paramedic partners to go through specialized training course designed for community paramedics, self-paced, online. They have 16 weeks to complete it. And it's really designed to prepare folks to take this IBSC CPC exam and enter as an entry-level provider to the community paramedic profession. This is a deeper dive into assessments, plans of care, chronic condition management, enhanced pharmacology and lab medicine, focuses on really everything that's needed in the non-transportation parts of the healthcare system, which is usually where MIH providers will come from initially, the traditional transport side. There are also clinical hours that will be done virtually and ideally in person as well. Our plan is going forward, we have a goal of tracking the impact of each of the different participants and what they take part in and their passing rate of the IBSC exam. Part of the reason we focused on the IBSC exam is it really is kind of the gold standard of this group and the community paramedicine MIH training pathway. And I mentioned the regulatory issues we're facing, and when you're one of the newer players on the block doing this kind of work, we do think it's really important that we show standardization, specialization, and capability, and can check all those boxes and also put the highest quality product on the field as possible. The other thing I would mention, kind of in closing, is one thing when you're thinking about whether you can use an MIH or community paramedicine paramedic in your hospital at home program is to really consider them strategic partners and not just someone you're hiring to go into a home. We found that strong partnerships, both national and local, allow an increased availability for partnership and the iterations needed to really improve as you both learn to be better at a hospital, at being a hospital at home program. It's a great opportunity to engage these types of new clinicians. Often these paramedics or acute care nurses working in EMS are not currently practicing their full scope of practice. And we've gotten feedback that they're often dissatisfied with the outdated 911 transfer model and are really looking to take part in these new innovative levels of care, especially in the home. It opens up career pathways for them, increased earning potential, greater job satisfaction, and all these things will be really critical to growing and maintaining this new role if you choose to use it. These guys do have an appetite for increased accountability and input into advanced primary care, population health. So if your program is also considering that type of work, we found that the type of medic that's interested in doing this MIH role in the home is also interested in that type of work as well. And when you're engaging local EMS providers or national EMS providers, you can make a compelling case that this is a new higher margin use case and more applicable for the future. That's
Thanks,
all I got,
Doug.
Dave.
Appreciate it. Curious, Zio, any kind of reflections or questions on the CP thing?
Yeah, thank you. This was great. I'm wondering, how do you train your paramedics when there's low patient census, if that's applicable to your program?
So that's really, really great question. So that's actually one of the main reasons we thought it was really important to develop that academy, the kind of boot camp beforehand, because you're right. I mean, anyone who's been involved with the hospital at home program knows that, especially in the beginning, the census is, I guess we'll put it, variable is probably the nice word to use. And so, you may have a time where until you reach that period where you're really humming, the low census count will mean that, okay, you've got this eager workforce ready to do this, but their reps are low. And so one of the reasons we thought about using mobile integrated health so completely in our program is also we found the same thing's true if you only use them for night and weekend coverage. If you have one group that covers Monday through Friday, 9 to 5, and then you have another group that only covers the off hours and weekends, they just won't have enough reps to really get good. And so in the beginning, part of that, 7 days right before we start, making sure that we've kind of primed these folks with the most reps we can right beforehand with high quality staff around. But you're right, that is a constant concern. And if you're finding your program going through some lulls, I think it's good to try to keep those reps up.
Thank you.
Yeah, great. And Patrick, what about you?
Yeah, curious, Doug, in the spirit of the interdisciplinary aspects of what I was talking about earlier, do you have any specific approach to how you have thought about training to, the communication, from someone who's in the home back to someone who's remote, and anything around standardizing, the presentation modes, et cetera?
Great question. And it's interesting because it goes both ways. We've gotten a lot of feedback that not only is there often not experience in giving that, in nursing school, med school, I don't know how many thousands of times you have to present the clinical information in the same standard way because it's happened. And so sometimes that happens by good, high quality medics, but they get to the ER dropping off a patient and someone literally tells them, okay, thank you, don't care, don't need to know right now, now they're in the hospital. And so it's interesting, there is both a real recognition that they have valuable information that is seen in the home and that others don't have, but also the desire to join a team that values that information. And so yes, there absolutely is standardization of how we talk and being concise. So if the hospitalist is on the line, they want to know the critical things quickly and not a 15-minute presentation. while still also developing a culture where, everyone realizes it's important what's in the fridge. It's important that you opened up the medicine cabinet and found a lisinopril from 2017, and maybe that has something to do with the hyperkalemia they keep getting admitted for. Yeah, I think great question, and definitely goes both ways.
Great. We're running short on time and have a ton of really great questions from the audience. A couple of quick rapid fire questions. Several people have asked, how long does it take to train a new person in your program? If each of you, maybe if we just start Zio, then Patrick and Doug, when you get a new RN or a new NP and Patrick, a new MD and a new paramedic, like, can you help us understand how long are we talking before they are flying solo, seeing patients?
So I think it varies based on the individual, and it's why you have to sort of do that needs assessment, have those debriefing sessions, get a sense from the nurse or nurse practitioner or whatnot, how comfortable they are. But it can vary. We've had nurses that are ready to start in 2 weeks' time. We've had others that can take 3 months, 6 months. So it does vary. And so you have to tailor your training program based on the individual as much as possible. Otherwise, you risk losing staff. And so we found that in order to retain staff, you really have to invest the time to train them, however long it may take.
Yeah. For us, I think, we do a full week of formalized training for our docs, and a lot of that is team-based as well. And then, I'll just reiterate that there's ongoing then mentored patient admissions beyond that. So you're never on your own doing your first, second, third admission. And then the closed loop ongoing professional development. So I think most folks are comfortable seeing patients without that in real-time mentorship after a couple months, but there's ongoing learning for sure.
My answer is pretty close to Patrick's. I mean, there's that boot camp beforehand, 7 to 10 days. Obviously, there's more work before that, but that's really the key, hands-on. And then, selecting folks that have an interest and desire and background that shows their capability to improve and take on this new skill set. And then there's that course afterward designed to prepare them for the IBSC exam. And then the important thing, I think, going forward is, again, like Patrick was saying, the continuing education, maintaining credentials. It can't just be a one and done thing, because if it is, what do you do about staff turnover and that kind of stuff? So you really do need to pay attention to new folks coming in as your program grows.
And also, all three of you mentioned using kind of asynchronous training of sort, whether it be virtual or modules. Curious, a couple people asked actually, and I think it's a great question. What sort of kind of simulated platforms are you using, or are you using virtual patient platforms, right? Like the good old ACLS training platform. Are you all leveraging any sorts of kind of platforms like that for your digital-based training?
We leverage a learning management system that's probably similar to what a lot of hospitals use in terms of some of those things. And then the other thing I'll add in terms of technology, we leverage our remote video devices to actually do a secure. So someone, say, that is brand new in Atlanta can actually watch an admission from an experienced team, say in Seattle, with the patient's permission, but learn by cross-pollination in that way as well, leveraging technology.
Yeah, for our program, we do a mix. Sometimes we use staff to serve as patients, and we have sort of a patient case scenario that we go through. A lot of the virtual component will be either modules. Our nurses and nurse practitioners will also join televisits virtually, where they get to observe, a full patient visit. So it's a mix.
Yeah, we have a medically home learning academy that our clinical team is, an informatics team has put a ton of time into, kind of pre-simulations prior to the boot camp. And then again, the asynchronous work afterward, and then the clinical case presentations with the high fidelity mannequins during the boot camp.
Wonderful. Yeah, so sorry we are out of time for additional questions. Lots of other great questions out there. Encourage you to post them to our Basecamp, which is kind of a very lively forum that we have where people are exchanging ideas and consistently interacting. Huge thanks to Zio, Patrick, and Doug. Thank you all so much for sharing how you've been training folks. Really interesting stuff here. Just another shameless plug and reminder to please save the date for our annual meeting on October 27th, totally virtual. Please stay tuned for more information on our website and on Basecamp. And again, for more information, hausersgroup.org, where we have quite a few technical assistance resources, including an annotated CMS waiver for everybody to learn from. And again, just many thanks to both the John A. Hartford Foundation that is able to support the Hospital Home Users Group, as well as our co-sponsors for today's event, the American Academy of Home Care Medicine and the American Hospital Association.